So what we want to do in this session is just describe my experience in Canada of trying to do the physician and hygiene, Justin's experience in Newcastle about trying to design interventions around diabetes. So hopefully sort of thinking about how these things can come together. But I guess one of the reflections, particularly on the kind of discussion we've just had, is a kind of, I don't know if it's a frustration, but it feels as though we haven't given you nice, easy answers. And we're sorry, but I don't think there are any nice, easy answers. And I think our plan today was to try and give you a sort of high-level view. But we could do this over a week, we could do this over a month. And so I think the issue that I would hope that you'd think about are the things that you've heard about today that might provide, that you think it might be interesting, worth exploring further. And then maybe we can give you a reading list so you can do some of that yourself. But we've also been talking with Paula and Jackie about sort of, there will be other, basically similar sort of masterclasses in the future, where instead of doing this very sort of high level, narrow thing, it may be this opportunity to look at things in more detail and have a lot more time to discuss. Because I think it's some of the things that we're talking about are things that actually just need to have good conversations over time. Okay, so I don't think we promised you at the start of the day that you'd know how to make life wonderful, but hopefully, if nothing else, you've got an idea that there are some things out there that you probably haven't heard of before or had been exposed to before that may be useful. So I'm going to come back to the physician hand hygiene. As I said, this was a priority for our hospital. I bumped into the infectious disease hand hygiene champion, Kathy Sue, and we decided, given that the hospital tried multiple things and we hadn't shifted physician hand hygiene, that this is something worthwhile trying to do a more deeper dive. We did interviews with 42 clinicians across a range of settings and also observation, and we talked about the kind of barriers that came up. If you go back to the Simon French model, you can then start to sort of develop things like, what do we need to do different? Physicians need to practice hand hygiene routinely. What are some of the barriers, beliefs about consequences? A failure to practice hand hygiene was not necessarily associated with the adverse event. And then you can start to develop intervention components. I tended to go from the TDF to the behaviour change taxonomy, or technique taxonomy, because that's the kind of way my brain works. One of the challenges when you do this is that you end up with a much longer list of things than you could possibly ever think about addressing. There are 30 things you could do to try and do this, and you think this is not something that we're going to have to, or that we can't do all of them. And so there is a part of this process where you have to prioritize about, where do you think you're going to get maximum traction within the resources available. So this is where we come down to the idea that the implementation intervention should be based upon things like available resources, practicalities, and logistics. What we had, when we had our big long list, we had a meeting with so this is where it didn't take a huge amount of time. We had a meeting with the hand hygiene team, and we presented the stuff, we got them to talk about it, we talked about potential interventions, and then the kind of intervention design team went away and produced something. But it was actually probably something like a 1.5 hour session where most of the work was done, having done some of this background work. But the real challenge came to us in terms of thinking about how we could deliver a program in a real world setting. Because we were sort of thinking, what are the points where we could actually have some sort of contact with the physician groups we're trying to influence. And so our original idea was maybe we could do this at the handover period. In the morning, maybe that's a time where we could grab people and get some sort of educational session going at that point in time. But when we talked to particularly things like chief residents, they said, you don't want to do that. This is a time which is, you've got clinicians going off shift who are tired, clinicians coming on shift. There's a lot to do. And they're going to feel really resentful if you sort of try and steal some of that time to do this, because physicians don't particularly see this as a high priority. It's a high priority, they'd be washing their hands. Yeah, so actually sort of trying to take some of their protected time and to do this would be very hard. So we talked about, well, could we do this in medical rounds or something like that? And they sort of said, no one will come. You put a medical round, you say, hand hygiene, yeah, no one's going to come. What happens if you give them pizza? Well, they'll take pizza and they'll sit at the back and they'll play with their Blackberries or do their notes. And so it became apparent that we could build a really beautiful Rolls-Royce intervention, but no one would actually come. And so there's this real tension about, well, what can we do that will actually allow us to deliver something we think is worthwhile, but something that is also feasible within a really busy tertiary care hospital setting. And so when we talk to the chief residents, the residents in Canada rotate through a ward every month. So they could just go to a new ward in a month's time. And at the start of every month, the chief resident meets with the residents for half an hour orientation for that ward. And they're really jam-packed meetings. And we sort of said to the chief residents, is there any way that we could come along to those meetings? And they said, no, forget it. They're really busy, got a lot to do, not going to do it. But then one of them sort of said, well, actually, we've got 2 slides that we don't need to, we don't need to talk to people about. We'll give you 2 slides. We'll allow you 2 slides in our 30-minute slot with the chief residents. And we thought, okay, we'll take that. And the second thing then is, like, are there any other times where we might be able to go into a place where most of the physicians will be and we'll be able to access them? And interestingly, the chief residents have said, well, we have an antibiotic stewardship system, and every week an infectious disease physician will go into a hospital ward to meet with the medical staff to talk about their antibiotic problems. And the residents said, that would be a really great time because people go, and they go because it has value. The residents and the attending really find it highly valuable to go to these rounds. So most of them are there, and actually kind of hand hygiene fits in quite well with the idea of antibiotic stewardship. And the people who go and do the rounds are the people that we were, who actually asked us to get involved in the project. So they were kind of quite happy to do this. So we were in a situation where it was sort of, how can we design an intervention given the practicalities? So what we had is an intervention that largely focused on 2 points of contact and some change in the environment. And a lot of these were around sort of knowledge or beliefs about consequences of social influences. So in the 30-minute chief resident orientation, we had 2 slides which talked about the 4 moments of hand hygiene, so that was a knowledge issue. But just reminding people to think about the 4 moments of hand hygiene, and most importantly, what the patient's environment was. So those are those areas where you should be washing your hands, but this is the kind of detailed level. And then to talk about the importance of this from the hospital's perspective, we have a particular problem with both hand hygiene compliance rates, but also we have problems with infection rates. So actually, within that sort of setting for the chief resident to be saying, this is something that's a priority for the hospital, and it's a priority for this ward, we thought was potentially useful. The other thing is having the chief resident delivering this was really important. The chief resident can make your life easy or difficult. The chief resident is one of the people who will basically draft your reference for wherever you're going to go to next. So residents want to be good friends with chief residents. And so this was something, there was a kind of social influence overlay that we could use because of this. In terms of then using the antibiotic stewardship round, there are probably 10 or 15 to 20 minutes in any one ward. So you couldn't go in and say, let's have a half hour on hand hygiene because everyone would just run away. So we negotiated the idea that we would develop an 8-minute curriculum that could be delivered 2 minutes a week over the 4 weeks when we're seeing the rotation of residents as being part of the process. And so some of the things were, again, reinforcing the issue around links between infection rates and hand hygiene, the 4 moments and the patient environment. And the other thing that we added into this would be something called glow germ. So people in hospital may know this, but basically there is a gel that you can get people to knock and wash their hands and then look under an ultraviolet light and find out that they've completely missed their thumb. And I really didn't want, I just felt rather like a gimmick to me. I really didn't want to sort of do that, but everyone said, no, you should really do it. And what we found is that, so that's what we did. Again, what we thought, the fact that it was Kathy Sue or Virginia Roth who were going into the wards, who were highly credible to the clinical communities, giving this message was really important. We also trusted them that they would actually sort of, they wouldn't sort of slavishly say, now we're going to do our 2 minutes on hand hygiene, but they'd find a way of slotting this in and making it relevant in terms of the other conversation they're having, and they'd sort of tailor it to whatever was needed. So that's what we did. And then in addressing the environmental barriers, we wanted to sort of try and deliver and make sure that the hand hygiene resources were easily accessible and noticeable, and also that they were routinely topped up. So just sort of going back to the ward and saying, how can we establish a system where that issue is taken out of the way? We did a fidelity check. First of all, we had very good attendance at everything. And then we asked whether people could remember what was done, and they had really good recollection of what was done. They really liked the glow germ demonstration, which really pissed me off, but that was okay. But it was kind of this real issue where the practicalities of designing an intervention in a healthcare setting ended up being a major driver. The TDF helped populate things and helped us start to prioritize what some of the things we had to do, but there then became a kind of art of okay, how are we going to do this? And it's where, if you go back to my internal knowledge, external knowledge, and and behavior change expertise, the internal knowledge was key to develop something that might work in the round. What we've done so far is we've actually piloted this in a medical ward and a surgical ward, and what you've got here, the blue lines are the control groups, and this is changed from pre to post. And M1 is the first point of hand hygiene, M4 is the fourth, and you've got medicine and surgery. The key thing to show is that the red bars, which is the change in the intervention group, was always greater than the blue bars, which was the change in the control group. This is incredibly preliminary data. We don't see this as being in any way persuasive that this is working, but it's an evaluation that allowed us to say, well, it looks as though we may be onto something. And what we're now doing is we're actually repeating this over a 4-month period across 4 wards, and again doing repeat audits to see whether this is something that is deliverable on a larger scale, is sustainable, and hopefully it might be cumulative. I mean, one of our senses are if by the time you get to the 3rd chief resident lecture, and they're saying hand hygiene, that may actually have a cumulative effect. We don't know, we'll see. But this was just showing an example of trying to build an intervention, really using the process that we've done. It wasn't hugely intensive, and it was something that when we spoke to the hand hygiene leads, they sort of said, this just feels like it's a refreshingly different way, rather than having an edict that here's a sort of Ontario strategy that everyone has to follow and it doesn't quite fit into the hospital. This was trying to build things up from the ground for what was been an intransigent problem. Okay? Going to hand over to Justin, who's going to talk about diabetes in a slightly different way. We're okay for time. I don't need that.
Right. Thanks, Jeremy. So this is work that I think predated the TDF in terms of how it started to be used in an implementation context. But it started off with this recognition from within the implementation science literature that there seem to be 3 different levels of theorizing about what can lead to change, or what can help us to understand the behavior of healthcare professionals. There was what I might call the if you build it, they will come approach, which emphasizes the kind of underlying structural support systems that support behavior change. There's what I call the there is no I in team approach, which can be described as really change involving exchanges and shared processes between people that work in teams within organizations. And then finally, there's the kind of between the ears approach, which is all about people's perceptions about their behaviors, their beliefs, their motivations, and their goals. And really, the recognition here with the reason for running this study to begin with was the recognition that if we wanted to choose a theory to begin with, we didn't have an evidence base for deciding on which level to begin with, and even within each of these 3 levels, there's a range of theories which, again, we didn't really have an evidence base for selecting. So we ran this study, and when I say we, I mean Martin Eccles as the PI, but also involving Jeremy as well, to try to answer that question, to have a look at which theories seem to be most useful within a diabetes context. So this was a national study, which we called the IQUAD study, Improving Quality in Diabetes Care, which was run across the whole of the UK. Was interested in trying to understand 6 different clinical behaviors that were recommended in NICE guidance at the time. So 2 for prescribing around blood pressure and HbA1c, 3 for providing different evidence-based ways of providing advice around self-management, weight management, and education, and a foot examination behavior. And really, we were interested in testing our theories, testing which theories help us to understand those behaviors best. So this was conducted across 99 practices across the UK. Basically asking clinicians to fill out questionnaires at baseline and then predicting what they did 12 months later. So we had outcomes at the clinician level in terms of what clinicians reported doing after a year, but also at a practice level in terms of patients' report of the care that they received and anonymized patient records at the practice level. Won't go into detail about recruitment or anything. We had relatively good response. But I think that the key point here is, first of all, we were able to identify key gaps in the quality of care across the 6 behaviors we looked at. And we're also able to start to empirically identify particular theory-based factors that were and weren't helpful for understanding these 6 behaviors consistently. So this is just a list, and I won't read it out. It's just our way of describing that target, action, context, and time for each of the 6 behaviors. And to just give you a flavor of the findings that we had in terms of identifying how well or how much these were being performed. So as I said, we had a range of sources of behaviors, sources of measuring these behaviors. We asked professionals, we also had patient records, we also asked people with diabetes to report on care. So what we can see here is for pretty much across the board for what health professionals seem to, first of all, report providing the care to a greater extent than either the patient records or what people reported doing. So you may have explanations for why that may be the case. But I think the more important point here is that regardless of how you measure the outcome, foot examination potentially as an outlier to that, but for the rest of them, clearly there's gaps in care worth addressing regardless of how you actually measure the outcome or the behavior. So then when we looked at trying to look at those 3 levels, when we looked at the highest level, the kind of structural features of diabetes care, we were interested in, are staffing ratios important? Are whether they have dedicated meetings, if there's a dedicated diabetes clinic, how long appointments typically last, the level of admin support, if there's a recall system, if they can initiate insulin in the practice, if there's a structured education pathway, access to specialists, index of multiple deprivation, and list size. So we're sort of expecting these to be important in predicting behavior, but what we found, surprising to us, is really the only one that seemed to be correlated in any way with any of the 6 behaviors we were interested in was list size for 2 of the behaviors, in that the smaller practices seem to perform better than the larger ones for 2 of the behaviors. So that was surprising, but at the same time helpful for thinking about if we're trying to target an intervention, at least from this data, targeting these may not be as helpful for improving care in this population. We then looked at, we had an organizational psychologist on the team who identified 3 different types of organizational theories. And again, this predates the TDF, so this was about testing theories per se rather than TDF domains. And what we found here, again to our surprise, was the 3 different theories that we looked at in terms of, is there a good level of teamness? Do people feel that they're being treated fairly? And how much organizational citizenship there is in the practices? Neither of these 3 perspectives or theories were helpful. Again, surprising, particularly for our organizational psychologist colleague. And then we looked at behavioral theories. We looked at 4 different theories, so social cognitive theory, theory of planned behavior, planning, and learning theory. And here, thankfully, we did find that we did find that across all 6 of the behaviors, there were particular constructs or domains that were consistently predictive of clinicians' behavior, and were also, when we measured them, showed room for improvement, in particular for self-efficacy in some of the planning. So the point here is that this approach to trying to identify barriers or targets for intervention allowed us to, first of all, rule out targeting the higher level features, particularly for these 6 behaviors. Not to say they're not important, but we didn't show them to be important in predicting the behaviors. So what we did show was certain behavioral theories were relevant, and in particular social cognitive theory with some components of habit and planning seemed to be most consistently predictive across our behaviors. So again, starting to develop an evidence base for, right, we might want to develop an intervention to target these factors to increase the levels of those that have lower levels. Alongside trying to identify those behaviors, we're also trying to pick up on what Jeremy was mentioning about the kind of the thinking of, is behavior more of a reflective process about making decisions, or how much of our behavior is actually more automatic and cued by our environment? And so we use the same data to really explore that. And this is this idea of dual process models that, first of all, most of the time we think our behavior is about making actual decisions in everyday life. That's that whole reflective process that's more about weighing pros and cons, being analytical, making decisions. It's very conscious and deliberate. But dual process models suggest that alongside that, conscious decision making that we're aware of, is that more cued aspect, that we're triggered by certain features of our environment. Some of our behavior might be routinized, and might be important to understand how much of our behavior is actually routinized and automatic if we're thinking about trying to target an intervention, for the reasons that Jeremy mentioned. Because if we find that that is relevant and we're ignoring that impulsive process when trying to change behavior, it shouldn't surprise us if we target a reflective process and then behavior changes and it goes back to normal after 6 months, because that impulsive process is maintaining the behavior. So I think what's exciting about this kind of dual process perspective is that it allows us to really recognize clearly there's some skilled decision making involved for clinicians. They need to make important decisions that have highly salient consequences. They're prescribing, which can have adverse outcomes. So there's a role for that reflection, that decision making. But clearly, as we all do, clinicians work in stable contexts with stable cues, the same sort of prompts, the same types of social cues from their colleagues or from the patients, which may involve some level of routinization that they may be more or less aware of. So we really wanted to get a sense of, does that actually contribute to understanding behavior? And the short answer to that is, when we tested that, we found that indeed there was support for that understanding of that reflective process across our behaviors, but also a role for that more automatic impulsive system, suggesting that we should be considering targeting that. But also importantly, it was never the case that there was a behavior that was only driven by that automatic feature, which is reassuring. You wouldn't expect clinicians to be operating completely automatically, but it was always supported by that reflective process, suggesting we may want to target that level of impulsive aspect, and that's what I just said. And this is really just an attempt to link this back. So whilst it wasn't at all informed by COMBI or the TDF, we could think of the results from that IQUAD study do map on or aggregate up to really suggesting that we need to focus on capability and motivation, and really the physical and social structure seem to be sufficient to support the behavior, and really to focus down on those two. So we got some money from Diabetes UK to run a local cluster randomized trial to really build on what we found in that IQUAD study and target the factors that we found to be predictive. So I'll quickly run you through where we're at with that, just as a kind of local example of how to design an intervention based on that evidence base. So this is just really quite hot off the presses. Protocol just published in Implementation Science last week for the trial if you're interested in more of the details. But I'll quickly walk you through it. So it's the same type, based on the same evidence that clearly gaps in care worth targeting. And what we did was we have a typical cluster randomized control design, stratified by practice size, which was, as you remember, the only structural feature that seemed to distinguish some of the practices. But we also built in a lot of underlying process evaluation to see, if we target these factors that we identified as predictive, are we actually managing to change those as well as the behavior? So that's that theory-based process evaluation. And we also built in quite a lot of fidelity of delivery, which is becoming, we haven't quite touched upon, but it's becoming more and more recognized that you might have a Rolls-Royce intervention or even a Ford Focus intervention, but if it's not being delivered as you intended, you may be evaluating something that could work, but it's just not being implemented as you expected. So we're really looking into, are the people that are delivering the intervention actually delivering it as we expect them to? So this is, what I find really exciting about this particular trial is that it's an implementation trial. So our target participants, our outcomes are health professional behavior outcomes. We're interested in secondary outcome measures at the patient level, but really the intervention itself is designed to change clinicians' behavior, which tends not to be the case for a lot of diabetes type interventions. We doing okay for time? So timeline-wise, we're sort of halfway through the project. We've randomized all the practices, delivered the intervention to 22 of the practices, and we're sort of in that waiting for data mode, which is going to start in the next 12 months. This is just another way to describe that. That's in your handouts. I won't dwell on for too long. This is more to make the point that we were explicit about trying to be clear about how we think the intervention is going to work. What are the particular theoretical constructs or domains that we think that we're designing or that we've used behavior change techniques to target, and we'll use that as a basis for saying, if we manage to change behavior, is it because we managed to change people's levels of action planning and coping planning and automaticity, or is it that we've changed behavior completely through another route altogether? And in terms of, so this kind of goes back to what you've been working on yourself in the case studies, is we specifically mapped behavior change techniques, so from that 93 list, to specific target constructs, and built that into a 90-minute workshop that we're delivering to different practices. And what we tried to do is to describe the content of it, to describe the intervention components in a separate way. So we've specifically distinguishing the content. So that's the techniques that we're using and the target constructs, but making that different, distinguishing that from who's actually providing it, in what format, how they're doing it, in what setting, who's receiving it, how intensively, the duration. So trying to be very systematic and explicit about all those different components, mainly because if we find it works, we think that having that level of detail might be helpful for someone else, trying to replicate it if it is successful. So when we look at the format, essentially what we started off hoping for a 3-hour workshop for practices, but quickly through our usability testing realized that there's no chance that we could get a 3-hour workshop with busy health professionals. But we managed to work our content into a 90-minute workshop that was actually delivered at the practices themselves during protected time that they had within the practices already. Using a range of different modes of delivery in terms of typical PowerPoint slides, but a lot of workbooks, small group tasks, and some video case studies, and providing DVDs of all the materials as well. So this is delivered, and we were really focused on the kind of source credibility of the intervention, that we wanted to have a behavior change expertise within it. So one of our facilitators is always a behavior change expert, someone trained in health psychology. But also, the second facilitator was always someone with a medical or nursing background to complement to provide the clinical expertise and the credibility on both the medical, clinical side as well as the behavior change side. So this is delivered, as I say, in the Northeast. And as I say, we're putting quite a lot of effort to really understand our facilitators delivering the intervention as it's been designed. Are they delivering the techniques as we think they are? I'm putting some effort into that. Process evaluation, as I say, really looking at, are we managing to change the factors that we think are going to drive the behavior change? But also building in some TDF-based interviews after the 12-month follow-up to get a sense of how do practices feel about having participated in the intervention, having changed or not after 12 months' time, and looking at that from an explicit framework using the TDF. And our health economists are covering the cost analysis side of things for the intervention. So I think that's more of a whistle-stop quick tour, mainly to stay on time as well, but to really just to highlight that designing interventions involves starting from assessing barriers to change, identifying potential interventions to address them. We hope we've convinced you, or at least suggested, that behavioral theories might be helpful to inform the first barrier assessment aspect, diagnosis, and potentially even to inform what strategies you might want to use for choosing an intervention. And this sort of mapping process might be a technique that can allow you to actually map those techniques to different barriers. What did I mean by fidelity of delivery? So that is whether or not, so we have designed intervention to include certain techniques, and what we're checking is whether or not the people delivering the intervention actually deliver those techniques as we intended. So we're audio recording each of the sessions and having independent coders code whether or not have they delivered the range of behavior change techniques that we intended to include in the sessions, or are they changing the content of the intervention over time? Mainly to see, are we staying consistent across the sessions, and are we delivering as intended? Does that answer your question?
Okay.
I'm not sure if I've missed something, but right at the beginning you talked about multifaceted interventions, and you said there was no evidence, or was that multifaceted, but yet you've both described complex interventions, and the work we've been doing this afternoon is about complexity of interventions. Mm-hmm. So can you discuss that with us?
So when I sort of said multifaceted interventions as developed, which often are sort of seems to be a kitchen sink approach, we just throw anything we can think at and hope it's something will stick. There's no evidence that effects are larger than single interventions. I think what you've got through both sort of Justin and my example is, kind of a careful work through arguments about why we think we're doing more than one thing, because we think there's more than one barrier, and that we're putting things together that we think would be additive rather than just synergistic. So it could be, I mean, there are certainly examples. We've done trials of very simple single interventions that have quite profound effects on changing behaviour, and we should use those where we can. But I think also this understanding of barriers, and particularly if you've got persuasive evidence that barriers are occurring at more than one level and might need different approaches to address them, then we should actually look at that. But I guess one of the other things I'd say is, if you take what Justin's example was, if you did a typical systematic review, you'd say that was one intervention. It's an educational meeting. But actually what you've got then is actually within the educational meeting there are 10 different change techniques as part of that. So it's where we're at the moment. And I think the argument that we've got to find out scientifically is, are carefully designed multifaceted interventions that target different barriers, and there's coherent project logic, more effective than single interventions, and are they more effective in a way that makes it worth the extra additional resources that you have to deliver them? So it's a kind of, I guess my original thing this morning was there's almost a knee-jerk sort of view that if you do more, you get more back, and the evidence doesn't suggest that. I think the argument is the argument that we're articulating is you need to do a fit between the barrier and the intervention, and sometimes that'll be single, sometimes it will be multifaceted. Yep. Any other comments for me? Yep, one over here. Just behind you.
You mentioned fidelity of delivery. What about fidelity of receipt?
Yes, absolutely. So that we're touching upon with a feedback sheet to see whether certain components are being received. But indeed, there's a range of different fidelity things that I didn't get into. That I think the fidelity issue generally is overlooked and really fundamental to understanding whether or not interventions work. And we could have fantastic interventions out there that are just not being delivered or received as we think they are.
Okay, I think we need to move on. So one of the things is what you had from Justin is not only a Rolls Royce, it's a gold-plated Rolls Royce. This is a sort of, probably one of the most sophisticated implementation research projects that has been done. The good thing is, it demonstrates you've got a lot of capacity in the Northeast to make really ambitious implementation research. I think what we've talked about today has not been at that level of detail, and I don't think either Justin and I would say this is what we think the health service should be doing, because it really requires a level of resource that you're not going to have. But I think some of the other things we've talked about, we would see probably the TDF as a way of trying to make that sort of, that more deeper, even deeper dive into psychological theory that Justin described more accessible to people working in service settings. Okay, so again, I'd see Justin's case example of what we can do, and also it's the sort of thing that we need to develop that evidence that will address the issue of, well, if we build multifaceted interventions targeting different mediating pathways, do we get the effect we do? But I think in a service setting, there's a much more sort of simpler, but hopefully a model that hopefully is still helpful. So I just want to finish off with a few final kind of reflections. As I said, I think the aim today was to give you a very high-level view of an evolving field, but hopefully giving you the idea that there are emerging bodies of knowledge that may be helpful for the work that you're doing. It is a relatively new field. There's been relatively few people engaged in the field for more than 10 years. Despite that, we actually have a lot of evidence. And I think if we're thinking about how to improve quality of care, implementation in healthcare settings, we should, in healthcare settings, be trying to use that knowledge. The issue is it requires also people like Justin and myself to try and make the knowledge accessible and easy to use. So I think we need to think about, or hopefully, how do we bring implementation science and scientists to engage with healthcare systems in a way that allow healthcare systems to achieve their goals. One of the things that I think we want to, or one of the areas that I think is worthwhile exploring, is the idea of implementation research laboratories. So quite often, when I was an implementation scientist who wanted to do a project, I start with a sort of blank sheet. I design a project. I have to convene a project team. I have to go and get funding. I have to then go and engage with healthcare system partners, and then run the study. Normally, the study or the funding finishes before the study is completed or written up. And when the funding goes, the team goes, and you end up trying to write up the study while you're doing your next study. And there's a lot of inefficiencies in that process. You lose the intellectual sort of learning, the team learning within your project team because they've dispersed and gone elsewhere. It means the next project I have to start negotiating with the healthcare system again to do different areas. And you often are sort of struggling in terms of writing up. I think that we're moving into the area, particularly where you have a healthcare system like the UK, where there's an obvious recognition of the importance of implementation. You have initiatives like the academic health science networks, where there's opportunities to say, are there different relationships between the implementation researchers and the implementers in the healthcare system, and that we might want to think about developing research laboratories. And this would be where the research team is integrated into the healthcare system, undertaking programs of research that are directly relevant to the healthcare system's priorities. It sounds like COPD might be a priority for the HSN in the next wee while. That's fine. Are there ways in which you can bring implementation researchers to work alongside implementers to actually address that? If we could get that integration, it would reduce the problem of developing a de novo research team, seeking project-by-project funding, negotiating access for the healthcare system, and then some of these other issues about finishing it. I think there's also opportunities for formal and informal linkages. So what you've got today has been sort of Justin and I presenting in a kind of fairly formal environment. But imagine if there was a kind of a project where people try to develop and you had people engaged in implementation of the service, but Justin was just part of the team, or I was just part of the team alongside that. I think there would be a much more enriched conversation from both sides, that both groups would learn a lot. And I think the other thing about having an implementation research laboratory is the other problem, if you like, as a research project, parachute into a clinical area, when you leave, the intervention often leaves with you. And I think if you've got an implementation laboratory, it's more clear that you're saying to the healthcare system, we're going to test this, and if it works, then we're hoping that you might be prepared to take this on. So I think there's some sort of interesting opportunities that might be possible to achieve in an area like the Northern region with both the Academic Health Science Network and NEQOS. Here's an example of another research laboratory I was talking about earlier. So this is a triads program in Scotland. In Scotland, there is a community dental guidance program. So people develop guidelines for community dentists called SDCEP. And alongside the guidance development program, we got funding to actually do a barrier assessment and intervention thinking while the guideline was being developed. So there's a protocol published, and then what you have here are the pink boxes are what happens in terms of guidelines development, and the blue boxes are what happens, what the research program is doing on top of that. So as the guidance is being formulated, the implementation program is trying to define what the key professional behaviour outcomes are. While the guidance is being developed, we're doing a diagnostic assessment. We're doing a kind of TDF assessment in terms of, what are the drivers of the behaviours that we think will be targeting the guideline? And does that help us then think about developing potentially sort of interventions? And there's been times when we've developed interventions and just passed them directly to the NHS, to the NES. Is that a Scottish? Do you have the equivalent of NES? It's an NHS Education Service in Scotland. So we develop an intervention and it just flows into the Scottish Health Service. Other times we've actually conducted research. But there's different. I think there are opportunities for different relationships between academic programs and service programs that will actually, I think, serve both communities well. And I think there are opportunities here to think about that. Another couple of sort of comments. We're starting to see the development of core competencies. So, I think I don't need to become a psychologist, but I need to have a fundamental grasp of some of the key concepts in psychology and know how to work with Justin. So, what are the kind of competencies we need for those people who are going to do implementation service settings, and how do we actually provide coursework to support them? And then finally, also, in the last 8 years, we've developed a core journal. I mean, a number of you already know about this, but if you don't, this is actually a journal where a lot of the discourse is coming out about these sort of areas. So implementation science as a field is developing rapidly. I think a key challenge for implementation science is how does it intersect with healthcare systems to make sure that if we're developing insights over here, healthcare systems and our patients are benefiting from that. And again, I think there's an opportunity with the structures that are being put in place to explore how that might move forward. So just to summarize, I think that's just what I've said. And okay. I mean, I think we've got just 5 minutes before we finish off. We've had discussions that have gone through. I guess we'd be interested in any reflections that you have in terms of what you've heard today. Useful, not useful, would have rather been at home with the kids, would have rather been outside in the rain with the kids, would have rather been anywhere but here, or gosh, that's the best thing I've ever heard, and what I want to do is go and sort of stalk Justin for the next 5 years, or but any kind of last or comments that people may have from the floor before we hand back to Paula and Jackie.
To what extent do you think implementation science is taking a bottom-up approach as well? So, for instance, in your GP interventions, at the same time, are you running a study with the people who are on the receiving end of the intervention so that you get that real life is messy view as well to find out, you might get the outcomes from GP interviews and from medical records, but what about data from the patient population to see what's actually happening and why behavioural change in that population may or may not be happening?
So I think that's, again, talking about the kind of almost a multi-level, and there's lots of different perspectives. So if you look at sort of the field, I've largely looked at changing professional behaviours, and that's what often Justin has been doing. Although a lot of the models we're playing with are things that have been developed looking at changing our individual behaviours, but I have colleagues who are looking very much at the level of implementation or support for citizens and patients as they're making health choices. And again, one of the issues for a healthcare system like the UK, we need to link these things up. I have other colleagues who are sort of looking at the macro health system level, and we need to find a way of linking them. So you've got a sort of particular face of implementation science, but if you actually go to, say, the journal, it's a lot broader with a lot more different perspectives. And again, it's part of that complexity. No one group at this point in time can probably cover everything. So we tend to say, I look at this bit, but we know that someone else is looking at another bit, and wherever possible, we're at least trying to talk so that there's some overlap. Last week I had a very interesting discussion with Graham Curry from the Business School in Warwick about actually I think there's probably time now where we can bring some of our models together in a way that would be helpful when he's been very much focusing at the kind of the macro organisational level.